TV. Talking about breast cancer myths, we have Dr. Brett Parkinson here. He is the head of the Imaging Services and the Breast Care Center here at Intermountain Medical Center in Murray. Thanks for being here.
Well, you know, it's delightful to be here, and it's always good to get the word out, especially with you, Mary, because not only have you been a supporter, but you've been through the process.
It's kind of funny. I was trying to think of, I'm not a reluctant spokesperson because I want to speak. I decided that cancer volunteered me. Is that a good way of putting it?
That's a good way of putting it.
I guess because I'm going to do it, because it's going to work, and hopefully it will reach more people.
And you were such a willing volunteer, and we appreciate it. And Mary, you need to know that women come in, and a lot of those women say, I'm here because Mary Nickles was here. She was a good example to me, and I think one of the things that was very helpful is that you were under 50 years old. So that debunked one of the myths out there, is that women under 50 don't need screening mammograms.
Well, and I'm surprised. We've learned so much together in the last 2 years, but that women feel like they're not at risk. Utah women were, what, second lowest in the country?
Right. When you look at national statistics for screening, Utah either ranks last or second to last in the percentage of women who are eligible to be screened. That means they have Medicare or they have insurance, who get screened not just every year, but every 2 years. Only about 65% of those women get screened. So that means that 35% of them are never getting screened, and most of them are not screening every year. So you would think that with the highly educated populace that we have, we would be doing better, but we're not. Now, once we do screen women, we do a great job of getting them through the treatment process. But our problem is getting the message out that women should be screened.
That's right. And one thing, you did one survey and showed that a lot of Utah women just don't think they're at risk. If they don't have a family history, they don't smoke, they take care of themselves, then they think, oh, I don't need a mammogram because I'm not at risk. But you are.
That's a great point. The problem is with this risk is that when women don't have a family history and they don't have other risk factors, they don't have the breast cancer gene, they think that they're going to get off okay, but they can't, because 75% of women who develop breast cancer are the first ones in their family.
75%?
75%
have no family history?
Have no family history whatsoever. They are the first ones to get it. In my particular family, my mother was the first to get breast cancer. Then after her diagnosis, she started having cousins, an aunt, and she was the very first one. So I think it's important that women remember that they are at risk by virtue of being female.
Right.
And that they have a 1 in 8 chance of developing breast cancer in their lifetimes.
See, and I was assuming, I have, my mom died of colon cancer 19 years ago, and my dad had colon cancer 2 years later. So, and he survived, but we caught it early because our whole family now does the screenings after mom died of it. So I was thinking colon cancer is one thing that I would be concerned about, and I do get screened for that, by the way. So I didn't realize that a mammogram, I mean, I've been getting my regular mammograms, but I didn't think I was in any more risk than anybody else. And I'm not. I'm at the same risk, and I got it.
Right, you're at average risk.
But we caught it early.
But we caught it early, and if you think of screening mammography like colonoscopy, it really is analogous. If you catch an early breast cancer, it's like catching a polyp in the colon early.
Right.
You can snip it out and go on with your life. And basically with breast cancer, if we find it in the earliest stages, we can excise it or do a lumpectomy, get it out, and a woman can go on with her life. And she can survive it.
That's right.
And that's the good news.
Catch it early. Okay, we have someone on the phone, Harleen from Riverton on the line. What's your question, Harleen?
Yeah, last year I got called back and my daughter-in-law got called back, and 2 years ago my daughter got called back from screening mammograms. Is it really necessary to do all these callbacks because they were all normal?
And it's so scary when you get that phone call saying, hey, you need to come back. It's that's really scary.
You know, that's an excellent question, and thank you for it, because one of the things that I think the general population needs to know is that 10% of women who undergo screening mammography will get called back. That is a national average. That's our average here 10%. At Intermountain Medical Center as well. And most of the time, over 90% of the time, there's nothing wrong with those women. There is either overlapping tissue, or there's a cyst, or there are calcium deposits that are benign. But the only way that we can know for sure is to call you back. Now, regrettably, your family didn't win the at the mammography roulette table recently. But when you look at the overall population, 9 out of 10 women who have a mammogram at just about any facility in the country will walk away with a clean bill of health. What we try to do here at Intermountain is let you know within 24 hours whether or not you need to come back. And if you do need to come back, we try to get you in within 24 to 48 hours, because we understand that that period between that devastating phone call and your diagnosis is crucial and it's anxiety ridden. So we do our best to help you out with that. But just remember that 10% of women will get called back, and that the majority of those women will not have breast cancer. For every 100 women that are called back, only 4 of those women will have breast cancer, and that's out of 1,000 women. So if you're a woman walking on the street, asymptomatic, meaning you don't have a lump, you don't have a breast nipple discharge, anything like that, 4 of you will have breast cancer and not know it. That's why screening is important. But that also means that 996 women will not have breast cancer. But when you add up mammograms over a lifetime, that 1 in 8 will kick in, and if you live to be 90, you will have a 1 in 8 chance of developing breast cancer. But that's a very good question. Tell your relatives to keep getting screened. Mary,
of course.
Mary can tell you about the value of screening mammography.
Yes.
It is very, very important.
In fact, Harleen, I got the call back and I ignored it because I'd been called back before because I have dense tissue. And that dense tissue causes concern, and unless they have a series of mammograms to look at and say, oh, it's that spot, or oh, it's that dense area that we looked at last time. And then they can explain it to you, and then they have a record of your history of mammograms. But this time, they said, come back and get an ultrasound, and I said, oh, that's happened before, it's probably dense tissue. And I put it off for a few weeks. So don't put it off. Get back in there and get that second look if you need to.
Don't put it off, or you'll get a call from me. I had to actually call Mary, and I say, Mary, this is for real. You need to get in here. We have an appointment on Tuesday at 1 o'clock.
And that's when I said,
that's
oh,
when
crap,
you're coming.
It's the real deal. It's not just dense tissue. So, but follow up on the callback. Do it. It's necessary. If anything else, for peace of mind. Because a lot of times it's you were saying sometimes it's a fluid cyst. It's different kinds of cysts. It might not be breast cancer, but it's something that needs to be looked at.
Yeah, most of the time it's not breast cancer. One of the most common things that women do have in their breasts, particularly after age 35, are cysts. And we see cysts all the time. Once we give you a diagnosis of a cyst, then you can rest assured that that itself will not transform into a malignancy, and you can wait till the next year to have your screening mammogram, unless, of course, you develop a symptom, in which case you will want to come in earlier. If any woman feels a lump in her breast, she should come in even in between screening mammography so that we can take a look at it.
Right. Okay, and then as for the looking at the mammograms, and is there any way, I guess it's not physically possible, for somebody to be analyzing every single mammogram as it comes in, so you don't have to get that call back?
You know, that is an excellent question. That is called online reading. And there are certain institutions that will do that. What will happen is you will go in, you'll have a screening mammogram, and the radiologist looks at it right there. The only problem with that is that that causes the radiologist to be interrupted throughout the day. And with that interruption comes the possibility that there may be a misdiagnosis. So what we like to do is read all our screening mammograms at one time in a dark room, uninterrupted, and early in the morning.
Okay.
Because studies have shown that if you do that, interpret the mammograms first thing in the morning, and you are focused, that it is much less likely that you will miss a breast cancer. So yes, it would be very convenient to come in for a 4 o'clock mammogram and have the radiologist say everything's fine. But if you do that, you're interrupting the radiologist in whatever else she or he is doing to look at your screening mammogram, and you don't have that focus. This has been borne out by many studies, and so if you go to a high volume place that is reputable, most of those places will do what we call dedicated screen reads, when we read all the screening mammograms at once.
Okay, and that's a few pair of eyes and more focus.
Yeah.
It's just your earpiece here.
Oh, thank you.
There you go.
Okay.
Up in there. And then you can push it back in
Okay,
there.
thank you.
Okay, so you can hear the next phone
Okay.
call as it comes in. No, it's good to have it explained like that, because sometimes, I mean, when I came in, I could tell there was concern when Dr. Kendall did it, and he said, but he had to look at it. But it was when other stuff was going on, and it might not have been as close of a look, and I misread his anxiety. So we'll see. But now for more questions about mammogram, that callback. I mean, I know when I met with you, you said, yes, it is cancer,
Right.
but it's curable.
Right. In your case, if you don't mind my being a little personal,
not at
what Mary had was a little bit of distortion of the tissue. And I looked at this in conjunction with some of my fellow radiologists. We often consult with each other. If we have a mammogram that is at all equivocal or suspicious, someone will say, take a look at this, and we'll do that. Or if it's sufficiently suspicious on its own, we won't have to consult.
Right.
But when we looked at that, we saw that there was distortion of the tissue. So you don't always have to see a mass. And then extra views over that area demonstrated that it persisted. That was a worrisome sign, so we went to ultrasound.
Right.
And it was the ultrasound that clinched the diagnosis. Now, even though you had dense breast tissue, your cancer was caught on a mammogram. I think one of the myths out there is that if you have dense breast tissue, mammography is useless. It's not useless. It's more difficult, and dense breast tissue will obscure some cancers, but mammography is still a good test in young women like you who have dense breast tissue, and we were able to catch your tumor at a small size before there was lymph node metastasis.
Right. Right. Young women, that's why I love this guy.
Oh, no.
Okay.
Didn't she look great? She looked young.
We have Candy on the phone now. Candy in Salt Lake City, what's your question for us?
My mother is 78. Does she still need to have a mammogram?
That is an excellent question. Women over 75, should they have a mammogram? Well, when the United States Preventative Services Task Force came out with their new recommendations in 2009, one of the controversial recommendations that they made was that women 75 and older did not need to be screened.
Because they think you're going to die anyway, but if you're going to live, you should get your mammograms, right?
Right, and if you're in a nursing home and you're 75, then no, you don't need a mammogram. But if you're a healthy 75-year-old, as many of our Utah women are,
You have a few good years left.
some of whom have at least 20 to 25 years
Yeah.
left. My grandmother lived to be 98. My other grandmother lived to be 93. Then yes, you should have a mammogram. This is why the task force made that recommendation. They said in their report that they did not have enough data specific to that demographic. Well, the studies were not designed to look at 75 and older. So they said, well, you can get a mammogram if you're over 75, but you don't necessarily need it. I think that was a huge disservice to American women, to women all over the world, because as a woman ages, the incidence of breast cancer goes up. So a 75-year-old woman actually has a greater chance of developing breast cancer than a 65-year-old woman. So that's nonsense. And I think that your mother should have a mammogram, and she should have a mammogram for as long as she is healthy, or up until the point where she really only has a life expectancy of 5 to 7 years.
Okay, thank you.
That's
Well,
a
thank
great
you.
recommendation. Yeah, that's a great question. And we've had it asked before. So, yes, I mean, if you expect to live more than 5 years, 10
Right.
years, then you should have, breast cancer could kill you quicker than that.
Right. And
So why not find it early and solve the problem?
What we want to do is we want to not only prevent death, but we want to prevent the morbidity or the harm that comes along with the treatment of breast cancer. We would rather treat a woman with a lumpectomy than with radiation therapy. We would also rather treat a woman, if we could get away with it, with just a lumpectomy and radiation therapy and not chemotherapy. But sometimes those things are necessary. If we catch it very early, then maybe we can obviate the need for all of those more invasive treatments.
Another thing I've learned about the treatments, a lot of people lump everything together because, oh, my dad had this and that's what chemo does to everybody. And everybody's different. And that's what I've learned. I mean, the cancer's different, the body's different, and the chemical cocktail and treatment is different for everybody.
Right, and I know you had a lot of fear going into chemotherapy about work. Am I going to be able to work? Why don't you tell us a little bit about your experience with work?
Well, I think I was lucky because I only missed 4 days of work and I felt like crap. Chemo sucked. It was pretty bad, but I would get up and go to work, and that's what helped me get through the day. It's not for everybody. There are some people that are just like me, and they'll get up and go to work every day. Did a story with a trooper, a UHP trooper, Bonnie.
Right.
And she's the same way. She gets up and goes to work every day. She goes to chemo, and the next day goes to work and feels a little bit yucky a few days later, but still tries to get in some time at work. And that keeps you going. It feels like you're contributing and you're going to get through it. Okay. But some people, it knocks you back into the hospital. You need IV therapy. You need IV treatment just to survive the chemo, because the chemo is trying to kill you. It's killing the cancer cells, but it's also killing a lot of your good cells. And that's why it weakens people so much. But that treatment would be scary for a 75-year-old woman.
And the thing is sometimes we don't always give chemotherapy to the older age group. And it's not because we think they're going to die. It's because sometimes their cancers are more indolent, not as aggressive. And so it is rare for us to give chemotherapy to, say, somebody who's 85 years old, but it's not rare to do a lumpectomy or a mastectomy and sometimes do radiation therapy. I think the thing that's important to know is that every single cancer is different. The biology is different. And one of the things that we have found in the last 20 years of research is that now we're able to target treatments to tumor types. Because of your tumor type, you got a completely different chemo cocktail, if you don't mind my using the word. It's probably not the most pleasant cocktail you've had.
Yeah.
But then say somebody else would have. Because what they do is they look at your markers. Is it estrogen positive, progesterone positive, HER2/neu positive, and they look at other biomarkers. And based on those markers, they tailor your treatment. And this takes us to the importance of multidisciplinary care. It's getting a lot of people who are really smart and who know what they're doing to talk about your case in a group setting so that you can get the very best care possible.
In fact, I got that. I got the clinic together, and a bunch of, how many was, 7
Probably
different doctors, and all of them different specialties, looked at my case specifically. And it was in the week that we were waiting to find out if I tested positive for the gene, for the BRCA gene. And so while we were waiting, we had everybody look, and every doctor said, well, if it comes back positive, then this is what I would do. If it comes back negative, then this is and everything's different, even based on the gene, what your treatment is. So for me, luckily I was negative, but you talked about the HER2 positive and the different, my tumor was triple negative, which affected how you treated it.
Exactly. And you mentioned the multidisciplinary conference. What we have here at Intermountain Healthcare is a conference that convenes every week on Thursdays at 7 a.m. We discuss every single new breast cancer. All the surgeons come bringing their cases. A radiologist like me is present, a pathologist. Sometimes we'll have 7 or 8 surgeons, like you said. But in addition to the surgeons, we have radiation therapists, we have medical oncologists, we have our own geneticist who's there, we have people from the tumor board, we have people from the from our clinical trials. I mean, we have a plethora of people there. And at the end of that session, after we have discussed the cases, we have a game plan for patients. And then the surgeon or the physician with whom the patient has the best relationship takes the plan back to the patient and says, look, after looking at all the variables of your case, we think that this is the best thing. Now, if the patient actually wants to meet with some of those doctors individually, she can go to our clinic. We have a clinic that meets afterwards and talk to the individuals about that. But I think it's important for all women to know that they should have a team discussing their case. This is not a one-man operation. This is a team approach, and the doctors need to talk to one another.
It's a built-in second opinion.
It's a built-in second opinion, and third, fourth, and fifth. And so what you have is you have doctors agreeing on what to do. One of the biggest criticisms that we suffered as an institution, and that most institutions did 10, 15 years ago, was that I have great doctors, but they don't talk to each other. And that's not good when the docs don't talk to each other. So this is a wonderful opportunity. Your docs spoke with one another, and I think we came up with a really good plan. You know, there were brains smarter than mine figuring out your chemotherapy.
Well, and that's the thing. It's a lot of times it's overwhelming. I mean, not a lot of times. It's probably always overwhelming. As soon as you hear the word cancer and that you have it, it's very overwhelming. And I know my husband and I brought a friend. We had a friend come with us to our doctor's appointments so she could take notes and she could ask questions. Because we're not in our right mind. You'll hear a word and you'll hear chemo, and then your mind travels off here and you didn't hear anything the doctor just said. And my husband might have heard it in a different way. So for her to be taking notes really helped us. And that's one thing I've had people call and say, hey, what should I do? I was just diagnosed, and I always recommend taking an unbiased third party in with you just to have a level head.
And the note taking, or you can, if the doctor doesn't mind, you can record the conversation and say, would you mind speaking into this microphone so I can remember exactly what you said?
Or diagrams.
Or diagrams.
Give you the paper. Keep it, because that makes sense to you.
What I do sometimes is I will actually take the woman to the monitor and I will show her where the abnormality is. So it demystifies what's going on. She can actually see what's there and have a mental concept of how we're going to attack it.
Okay. I think we had a call from Oh, one of the myths, good suggestions. Are mammograms painful? And real quick, I want to say the number again. It's 801-507-2807. If you want to call in with a question, we'll take those questions. But one of the myths is mammograms are painful. And I remember for years I've hated the jokes that remind women how painful they are, like put your boob in the refrigerator door and shut it hard. And I always thought, don't make jokes about it. It's not that bad. And that's why I ended up doing the story I did with Dr. Parkinson that found my tumor, is because I wanted to show people, and Intermountain wanted to show people, it's not that bad. And it is just a few moments of discomfort, maybe pain. And in my mind, if the flatter they get it, the better view you have of what's inside. Right?
If it starts looking like a pancake, we're doing our job.
Yes.
And that's a terrible thing to say, because a lot of women say you made me flatter than a pancake. And actually it does look a bit.
It doesn't stay that way.
It doesn't stay that way. And they do resume their original shape. So don't worry about a permanent deformation. No. Years ago on the Today Show, I think it was Jane Pauley who said, a mammogram should not be painful, but it is uncomfortable. And I think that's fair.
And it might be a little painful.
It may be a little painful. And the pain or the discomfort depend upon the woman. And for women who are still menstruating, it will depend upon the time of their cycle. So there are a few things that you can do to alleviate the pain for a screening mammogram. You can come when your breasts are not tender, and you know when that is during your cycle. Or you can pre-medicate with ibuprofen or Tylenol, and that will decrease the discomfort. So there's some tricks that you can use, and when you call and make your appointment, you can see if you can make your appointment around your menstrual period. That will help a lot. The other thing that helps is that if you talk to the technologist, and if together as a team you can compress slowly and you let the technologist, ooh, that's a little much, or that's not enough, and there's nothing wrong with saying you can compress me more. I have been in the room when the patients have said, you can actually compress me more. Now, why do we compress? Do we do it just to hurt you? No. It may seem like that, but that's not what we're doing. The reason we compress is that we want to get overlapping tissue out of the way. If you have a breast of this kind of thickness, you have all sorts of tissue fibers that are being registered by the X-ray beam as it comes down. If you flatten out the breast, then those tissue fibers will dissipate. And so you won't get what we call fake outs or summation artifacts. And that's important. That's why we do the compression. So tolerate as much compression as you can, because it's important. We will be able to see more. Now, we do have a new technology, and you've experienced that technology.
It's tomosynthesis?
It's tomosynthesis.
Okay.
It's 3D mammography. And what 3D mammography is like a CAT scan for the breast. As you know, a chest X-ray is two-dimensional, but a CAT scan takes multiple slices as it goes through the chest, and you can see a lot more detail. Well, there's a new technology called tomosynthesis, which actually allows us to see multiple slices of a breast. A 5-centimeter breast, we'll see 50 slices. And what that does is that takes away the overlap of breast tissue, so it decreases the number of women we call back, and that goes to the question of the first caller. And it also increases the pickup rate of breast cancers per thousand. We have a couple studies that came out just this year in 2012, both in the United States and in Europe, demonstrating that the increased cancer detection rate is 40% above baseline in situations where tomosynthesis is used against conventional 2D digital mammography.
Well, and I wanted to say that a regular mammogram, the tomosynthesis is done in the same machine. In the same room, at the same, at the
same time.
They do the mammograms and then they say, oh, wait a minute, let's do it, tomosynthesis on this, and it takes, what, 8 seconds?
Yeah, just 4 seconds per exposure more.
It's just a little bit longer. It's not even any more.
So
it felt like a mammogram.
Yeah, the patient herself isn't really aware, except that the machine looks a little bit different from the standard mammo machine. And there's an arc that goes across, and that is actually acquiring data to be run through an algorithm that then spews out 3D images for the radiologist. It's really kind of fun to look at. Yeah,
it was amazing. I got a chance to see it, and it is amazing to see how quickly it works and how quickly you can come in and look at it and say, oh, you're okay.
Right. A couple downsides of tomosynthesis, some insurance companies don't want to pay for it right now, as you know. But the the incremental cost isn't that much more than a mammogram. If you do other screening modalities like MRI or ultrasound, you're going to pay hundreds, if not thousands more. Right. Even with tomosynthesis, if women have to pay out of pocket, it's about $50 more is all. But we are working to get insurance companies to see the value of it, right, so they will reimburse that.
Right. Because I was thinking it would be something like scheduling an MRI and having to go to a different department and make it, and it's a big deal, and it's not.
And we believe this is particularly helpful in women with dense breast tissue. Okay. And once again, it is more difficult to find cancers in dense breast tissue. Check your report, because in your report, it will say whether or not you have fatty breast or dense breast or somewhere in between. If you have a really fatty breast, we have about a 99% chance of picking up the cancer in your breast with conventional mammography. If you have a very dense breast, then the chances fall to about 66-70% chance of detecting it.
Well, and we talk about breast cancer, and everybody lumps it into one thing, and it is so different. And that's one thing that I've learned about. I mean, and to see this on the tomosynthesis or even in a mammogram, early on you can see a different type of tumor or a different type of cyst, or you know if it's something to worry about or not.
Right. We look for changes in the tissue. We look for distortion of tissue. We look for the evolution of calcium deposits in the tissue, evolution of a mass or of an amorphous density that starts to appear. It's as much art as it is science, and the most important thing is experience. So I think the more we read, the more we look at our results, the better we get. That's one of the reasons that we track our results here at Intermountain Healthcare. We're lucky enough to have Brent James, who has actually led us through the process of looking at all of our data, comparing our data to national benchmarks, and making sure that we're doing a good job here, and that we can see areas where we need some improvement.
Well, and I know we have a lot to talk about the dense tissue and everything else. I think we're going to take a break real quick. Remind you of the phone number, 801-507-2807. If you want to call in with any questions, myths, we can answer them. We'll be right back.
Don't get sucked into the vending machine junk food trap. For help, visit intermountainlivewell.org.
Find your thing. For help, visit intermountainlivewell.org.
We need to go pick up my mother. She's joining us for dinner.
That would have been good to know. That would have been good to know. That would have been good to know. That would have been good to know.
Some things are good to know, like if you have colon cancer. So regular colonoscopies after 50 are key, because knowing early gives you better odds. Intermountain, live well. Take care of your heart. Your family deserves it. For ideas, go to intermountainlivewell.org.
Welcome back. We have Dr. Brett Parkinson here with Intermountain Medical Center and with breast care services here at this big, brand new, beautiful facility in Murray, and talking about the myths about breast cancer. And we talked a little bit about the BRCA gene, and I had the test done.
Right.
Because the type of cancer I had is very rare, the type of breast cancer, and it's more common in people who have the gene. And I tested negative for the gene, but then Angelina Jolie, the whole
Right.
story came out, and her mother had died of ovarian but
cancer.
she had the breast cancer gene, so she had her breasts removed. But I think a lot of people think, well, if I don't have the gene, then I'm not going to get breast cancer.
And
That's a myth.
And that's a myth. There are a couple important things to note about the breast cancer gene. Another reason that you were tested for the breast cancer gene is that you were under 50. So when young women are diagnosed with breast cancer, now under 50, we automatically test them for the breast cancer gene because a young diagnosis of breast cancer is more likely to carry the gene than, say, a 75-year-old woman. So we don't automatically test for the gene in women older than 50 unless they have a compelling family history to go along with their cancer, like a couple sisters with breast cancer, a mother, or if there is a smattering of ovarian cancer in the family. A few statistics. 1 in 400 women carry the breast cancer gene.
1 in 400.
1 in 400. So it doesn't make sense to screen all women for a gene that's not very common, because if you look at the test, which runs between $2,500 and $3,000, that would break insurance companies, and it would also break individuals who don't have insurance. So what we want to do is we want to tailor the test to a population group that has a higher pre-test probability of having breast cancer. So we do that by testing women like yourself who have breast cancer under age 50, and then we also look at family history. So we really recommend highly that physicians take thorough histories of their patients beginning in their 20s and 30s, especially for cancer. They need to ask about colon cancer, lung cancer, pancreatic cancer, but they especially need to ask about ovarian and breast cancer because they are linked. If a woman has a history of premenopausal breast cancer, meaning a relative who developed cancer before age 50 or before menopause, and maybe menopause was age 55, and particularly if she has 2 relatives with that, or if she has relatives, cousins, aunts with ovarian cancer, that she at least raise the question with her primary care provider about gene testing. The major institutions here in the Salt Lake Valley do have geneticists. We have an excellent geneticist here at Intermountain Medical Center who will meet with women, determine their risk, and test them for the breast cancer gene. We have found some breast cancers in young women who were asymptomatic because they went and they were tested for the gene, and then they had a screening MRI. Because for women who have the gene, we recommend yearly MRI. You're probably saying, well, why don't we recommend MRI for everybody? Well, once again, it's really expensive. It's about $3,000. It takes a long time. There are a lot of false positives. So what we want to do is we want to get a group of women to that test who have a high pretest probability of having the disease. So we have found some cancers on MRI screening in that high-risk population in women you might not ordinarily screen, 38-year-olds, 37-year-olds that had a positive family history. So it's very important that we identify those women. So if anybody watching this webcast has an unusual number of family members with cancer, particularly breast, ovarian cancer, contact your doctor. Ask your doctor about the possibility of getting tested for the breast cancer gene.
And have some facts. The next family gathering, make sure Aunt Zelda, you know, what did she die of, you know, and do we even know? But get those stories lined up so you know what your family history is. Because I didn't know until after I was diagnosed. I talked to one of my older sisters and she said, oh no, that's what so-and-so had. That's what our cousin had, or something like that. And then you realize, oh, I didn't even know that.
And then the question is, with Angelina Jolie, you were probably inundated with questions like, do you have to have a bilateral mastectomy? Well, actually, you don't. Now, Angelina chose to have a bilateral mastectomy because presumably at her stage in life, that was a decision that made sense to her. Now, let's take another scenario. Say a woman who's 30 who has the breast cancer gene. Should she necessarily have a bilateral mastectomy? Well, she can, and that would certainly be a reasonable choice, but does she have to? No, she does not have to. What she could do is she could screen every year with MRI with the gene, and she could wait. She has about a 60 to 70% chance of developing breast cancer.
That's huge.
So more likely than not. And she can decide at some point later in life when she wants to have the bilateral mastectomy.
Well, and that, they also recommend a hysterectomy.
Right, and the reason for that is that ovarian cancer and breast cancer are linked on the genes, the BRCA1 and 2. And it's actually more important to have your ovaries removed early than your breast, because we can screen for breast cancer effectively with MRI combined with mammography 3D mammography, but we don't have an effective test for ovarian cancer.
Right.
So I think the important thing for a woman to do who has a breast cancer gene, who is done with childbearing, is to consider a bilateral oophorectomy or hysterectomy with removal of both ovaries. And then, of course, that greatly diminishes the chances of developing ovarian cancer. Having a bilateral mastectomy greatly reduces the chances of having breast cancer to just a few percentage points. Instead of 60 or 70, then it's down to 2 or 3 percentage points, because some residual tissue is always left after a mastectomy.
Well, and we're talking about people who are positive for the BRCA, which is very rare. So
It's
that's,
rare.
that's 1 in 400.
1 in 400.
So the other 399 women still need to get screened.
They still need to get screened, because in that group, the probability of developing cancer is about 13%, or 1 in 8.
Okay. So 1 in 8 is...
Yeah, so 1 in 8 is the overall lifetime risk. And as we go through life, we find that we know more people with breast cancer. When you're 20 or 25 or 30, you don't know that many people with breast cancer except for family members. But when you get to our stage in life, in this particular decade, we know a lot of women who have had breast cancer.
Well, and it's funny, even at the Race for the Cure and with survivors, meeting young women. I mean, there were women with babies, bald. You know, they had chemo after they delivered their baby or before, and with breast cancer in their 20s.
Right. And so breast cancer does occur in younger women. Now, even though it does occur in younger women, we do not advocate beginning screening until age 40. Now, another controversial point with the task force recommendations is that in 2009, completely reversing themselves from what they had said in 2002, they no longer recommended routine screening in women between the ages of 40 and 49.
Right.
And of course, you remember that this happened just a year or so before you were diagnosed. And of course, that turned the breast imaging world upside down. They based that on faulty analysis of data, I believe. They included 2 studies in their meta-analysis of all the screening trials that had been done that had been debunked by the radiology and the oncology community. So we feel that they reached a faulty conclusion. They said, yes, it saves lives, but only 15% reduction in the death rate. That was a gross underestimation. If they would have used the appropriate trials in their analysis, they would have seen that it's closer to 30% reduction in breast cancer deaths. One irrefutable fact is that the death rate from breast cancer since I finished my fellowship in 1991 has decreased 30%.
Wow.
30%.
Because
So
we're catching it early.
we're catching it earlier, and we have better treatments. Chemotherapy is better, radiation is better, but the thing that really has made the difference is earlier detection with mammography.
Well, and I have had people say, well, they have all these fundraisers for breast cancer research and for this and for that, and that's why. We are getting somewhere. You know, you think you might be donating $100 and you're buying a Petri dish for some researcher in a lab somewhere, but they're making such huge strides.
They are.
In treatment, in research, in catching it early, in the breast, the triple negative.
Right.
That was found for me wasn't even discovered until 7 years ago.
We didn't know about the biology of triple negative when I was doing my residency. I think it's very, very important that women understand that the research dollars that are used are sometimes used right here in our own backyard. We have just finished a study here at Intermountain Medical Center where we looked at the survival rates of breast cancer patients who were diagnosed between the ages of 40 and 49. We're presenting this next month, and what our study showed was that there was definitely a survival benefit for women whose cancers were found on screening versus those women whose cancers were found when they felt a lump and not on screening. So we have our own data here.
Am I in that study?
Well, you will be eventually, but we
'Cause that was me.
We stopped in 2007
Okay.
simply because we needed 5-year data.
Okay.
But as time goes on, yes, you will be included in
Okay.
our study, as will many other young women be included in that study. So we're going to see this as an ongoing trial where we look at survival, and we have shown the survival benefit of mammography is irrefutable.
Well, and I love how you compared it to a colonoscopy.
Yeah.
Finding a polyp and taking it out, it's easy and you're considered cured.
Right.
That you take the cancer out, and you can do that if you catch it early. And my lump was tiny.
Right.
And I couldn't feel it, so I would not have found it without the mammogram.
Right, and in Mary's case, because she couldn't feel it, she did not have to go to surgery for a diagnosis, because what we did was under ultrasound guidance, we were able to guide a needle in and take a few pieces of the tissue. And then when the pathology came back as malignant, she underwent a lumpectomy after that. Now, about 2/3 of the biopsies we do are benign, so 2/3 of the patients for whom we perform biopsies don't have breast cancer and they don't have to go on to surgery.
Oh.
Back in the old days, when I was a medical student and resident, all of the women who had an abnormality on their mammogram or ultrasound had to go to surgery because we did not have the technology to do image-guided biopsies.
Right.
So what we would do is under mammography, we would place a wire into the abnormality.
Oh, okay.
The surgeon would follow that wire, take out a piece of tissue, examine it. If the woman had cancer, she would go on for a second surgery to make sure that we got the tissue around it and have all of her lymph nodes removed. That was an axillary dissection. So just 20 years ago, 25 years ago, the diagnostic part of breast cancer was very different and much more morbid. We have come a long way. We do much less harm than we used to. In the old days, when you had your lymph nodes tested, they all came out.
Right.
What about your experience?
I had 2 lymph nodes removed. They're called sentinel lymph nodes, meaning that they are messengers and they let you know if any cancer cells have gone out. And you do a radiation. You put in a radioactive dye before the surgery so that when they remove the lymph nodes, they run them off to the pathology while they're removing the tumor. And they came back and said your lymph nodes were clean. There was no cancer in the lymph nodes. So why did I still need chemo?
Well, you needed chemo because of the biology of your tumor. And we have found that women who are triple negative, women who have your types of markers, do better with chemo than women who do not. When women get chemo, it's not just a whimsical decision. It's based on it's based on as much science as it's based on as much science as we have. And sometimes we don't have a lot of science. And then we realize in a year or two that things are different and we will do something differently. But another word on the sentinel node, as Mary alluded to, really tells us what's going on in the rest of the underarm area, which is where breast cancer goes when it spreads. And we only have to take out 1 or 2 of the nodes. They're called sentinel nodes because they're really standing guard in the axilla.
Right.
And so we inject a dye at the time of surgery. We inject 2 dyes. One's a radioactive dye and one is a blue dye. The surgeon injects the blue dye, the radiologist injects the radioactive dye, and they both go to the sentinel nodes. So you really have almost a fail-safe way to get there. Either one alone will do a good job. So the ones that end up being blue or radioactive come out. Well, they did a study back in the late 90s where half the women had all of their lymph nodes taken out and half the women just had the sentinel node, and then they compared how long those women lived, and they found out that the survival rate was equivalent. And so taking out all the nodes was no better than just taking out sentinel nodes. Now the women who had negative sentinel nodes didn't have any other nodes taken out. The women who did went on for a full axillary dissection, and it didn't make any difference in survival.
But removing all the lymph nodes increases your risk of lymphedema.
Right.
And pain and other things that I haven't had any of that.
Right. The more surgery you do in the axilla, the more likely it is that you will develop a swelling in the arm or lymphedema, which can be uncomfortable. So we want to minimize that. We really want to minimize that.
Okay. And so there is progress being made with all this research. Now you talked about the effects of some of the treatments. And what about the mammogram? We had somebody ask about, what about radiation? The risk of radiation for a mammogram or MRI? I mean, we're exposed to a lot of things that are bad for us in order to detect a cancer.
The American College of Radiology is really taking a close look at radiation exposure. We expose women to very little radiation in mammography, but with other imaging modalities, we expose them to quite a bit. CT scanning is a big exposure. Those kinds of tests will really add up over time. A mammogram is very little exposure. It's really comparable to the amount of exposure you would get on a flight to Paris, because when you're closer to the sun, and pilots, flight attendants actually get a little bit more radiation exposure than we do because of the altitude. So you can consider a mammogram like a transatlantic flight. It's not quite as much fun. But for those of you who have kind husbands, maybe they could give you a trip to Paris if you'll get your yearly mammogram.
That would be nice.
So we want to put that in perspective. Can a tremendous amount of radiation to the breast cause breast cancer? Theoretically, it can. The studies that looked at that looked at the Hiroshima studies of radiation exposure, and they tracked backwards using a linear model to say that you would have to expose so many women to large doses of radiation to create one breast cancer. It really is minuscule, and I think we don't have to worry about that. You asked a good question about MRI. MRI is not radiation exposure. It's a completely different way of imaging. It's the realigning of hydrogen. So there is no radiation exposure for an MRI.
But it's exposure to something else.
Yeah, but it's, as far as we know, it's not really harmful.
Okay.
They do give you they do inject you with a dye, and that can have some side effects. CT, of course, carries with it a big dose. We do not do much breast CT, and ultrasound, of course, has no radiation exposure, and as far as we know is pretty harmless. And ultrasound is very helpful to us because we often use ultrasound as an adjunct or as an addition to mammography. If we see something abnormal on a screening mammogram, back to the caller's question about getting called back, often we will do an ultrasound, and the ultrasound is what tells us whether it's fluid-filled or solid. If it's fluid-filled, it's benign. We don't have to do anything. If it's solid, we can do a biopsy. So we have a lot of tools in our armamentarium that we did not have 20 to 25 years ago. When my mother was diagnosed with breast cancer in the 1970s, she didn't even have a mammogram ever during the process, nor did she have radiation therapy.
Okay.
So things have come a long way.
Right.
Of course, you know that up until 1980, the death rate from breast cancer was steady from the 1930s. We made no progress. So it was only after the introduction of screening mammography in the 1980s that we were actually able to appreciate a decline in the death rate.
In the death rate. That's fantastic.
But we've got lots of great technology out there, and I suspect that if we do this interview in 10 years, things will be very different again.
Even better, we hope. Now, we were talking about the radiation exposure, and you said cause cancer. Why did I get cancer? I mean, I've had somebody say, well, do they know how you got it? And is it my deodorant? Is it mammography? Is it I was raised under power lines? I don't know. I don't know why I got it.
You know, we actually don't know the reason for why women are getting breast cancer. We know that the incidence of breast cancer is going up, but women are also living longer. So we're finding more breast cancers as they live longer. When I first started my medical training, the thought was that it was 1 in 10, then it was 1 in 9. It's pretty much leveled out at 1 in 8. One thing we do know about breast cancer is that you can decrease your risk if you are normal weight. Women who are obese have higher rates of breast cancer, and the reason for that is circulating estrogen. They have fat in their body stores which will convert to estrogen, and we know that more estrogen on board will stimulate estrogen positive tumors. So being at a normal weight can help. We also know that breastfeeding can be protective against breast cancer. We know that alcohol consumption can lead to a higher incidence of breast cancer. We know that delaying childbirth till after the age of 30 can be associated with a slight increased risk of breast cancer. We know that starting your period very young or ending your period very late can also be associated with increased risk of breast cancer. So we know a few things, but we don't know everything, and we actually don't know what we can do yet to prevent it.
Well, and I kind of think that the increased diagnosis in more cases is because we're catching it so early.
Yeah, we are catching it early. And some criticize the radiology world for catching breast cancers too early, some that may not need to be treated. Well, we don't know which breast cancers don't need to be treated. Yes, there are some breast cancers that grow very slowly, and they may take 5 to 10 years. There is an entity called tubular cancer, and it's very slow growing, and it's something that would take years to really cause problems. There are also the in situ cancers, the cancers within the duct. Not every ductal carcinoma in situ will progress to an invasive cancers, but enough of them do that we don't want to take a chance. And so if you have an in situ cancer, you will at least have it removed. If it's low grade, you don't even need radiation therapy. If it's intermediate or higher grade, you may need radiation therapy. So we need to look at what we do and make sure that we're not overtreating. But at the same time, we don't want to undertreat, because the consequences of undertreatment could be devastating to the population.
Because I've heard of some people who chose not to have chemo. Or chose not to have radiation. And you do get to choose. I mean, you recommend, as a doctor, you recommend, you write the prescription, but it's up to the patient. to decide.
Right. Every patient gets to choose what she wants to do. We've had some patients who have gone against medical advice and opted not to have chemotherapy or radiation therapy, and then sadly within a few years we see that there's a recurrence. So that doesn't always happen. We've had some patients that have said, I don't want the aggressive treatment. I see them 10 years later, they're doing fine. There's just no way of telling. I think the safest thing to do is to follow the advice of your doctors, get as many opinions as you can. There's nothing wrong with getting a second opinion.
Right.
As a matter of fact, sometimes we send out our pathology cases to other institutions to get a second opinion
take a look.
if it's a tricky case.
Yeah.
Whenever we have a tricky case in the breast center on imaging, we always solicit a second opinion from one of our colleagues. We always do that.
Well, and we have so many great facilities in Utah. We're so lucky to be here.
We're very lucky. We have some very good breast radiologists.
Okay, we do have a question from a caller, Shirley from Murray. What's your question, Shirley?
If I feel a lump and it's cancerous, does that mean it's late stage and too late for a cure?
Good question.
That's a good chance. So if you feel a lump, does that necessarily mean that you can't be cured if it's cancer? And the answer is absolutely not. About 50% of the cancers that we find are cancers that the women or their doctors find themselves. We find about half of them on screening, meaning in women who have no symptoms, but the other half are in women who actually feel something. Most of those women survive their breast cancer. So just because you feel a lump doesn't mean it's too late. And one of the disheartening things is that sometimes I've had women that have had lumps and they have said, I've had this lump for 5 months, it may not make any difference, it may have spread already. No, the minute you feel the lump, come in, because it could be a superficial lump, it could be a small lump. The important thing is to get it in, get it treated as quickly and as appropriately as possible. So the answer to your question is no, it's not too late. And yes, you can be cured even if you find your own cancer. Most women who find their own cancers are cured. Most women who develop breast cancer in 2013 are cured.
Yeah, that's right. Good statistics. So thank you so much. Great question.
Yeah.
It is curable, and I've also heard of some women who say, well, even if they find it, I don't have insurance and I wouldn't be able to afford to treat it. So why do I want to know if I have it?
Oh, this really hits on one of the things that is near and dear to my heart, and that is the uninsured woman, or the woman who feels that she can't come in because she doesn't have the funds. There are societies, there are organizations here in the state of Utah that will help you out. There's the Utah Cancer Control Program, the Utah Department of Health. Call them. You can call our center here at Intermountain, 801-507-7812.
That's why you have fundraisers.
That's why we have fundraisers.
Pay for that.
And we just had a fundraiser in September. We raised thousands of dollars, thanks to Mary Nickles being there, for our fund to screen uninsured women. If a woman is screened and she's found to have breast cancer and she doesn't have the money to pay for it, there are organizations within the state that will pay for her treatment, and she also can probably qualify for Medicaid, and that's important because Medicaid will also pay for treatment. So please, 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 if you are within the sound of my voice and you feel a lump or you need to be screened, don't let the finances get in the way. There are things that we can do for you to make it so that you can have the funds to be appropriately treated.
Well, and I've also heard of some women who will feel a lump and think, oh, it'll go away. Or, well, it's probably not like invasive. I mean, the tumor I had was already open and invasive. But there are a lot of breast cancer tumors that aren't open. They're just getting bigger. They're not spreading to your other organs. So why bother cutting it out?
Right. Any lump that you feel should be attended to.
Okay.
And usually what we'll do is a mammogram, and often we will do an ultrasound to go with that. And if there's any question, we'll do a biopsy. As I mentioned earlier in the webcast, about 2/3 of the biopsies which we perform are benign, 1/3 are malignant. So chances are you won't have breast cancer, but there is still a chance that you could have breast cancer. Please don't not come in because you don't have funds or because you feel the lump may just be benign. There's no way of knowing unless it's imaged or actually, in some cases, sampled.
Well, and I'm also surprised that people will call and ask me questions now that they know I've been through a lot of different things, and they'll ask what I should do. I love it when people call actually and say, what can I do for my friend who was just diagnosed? How can I help him the most? And so I've been really lucky to be able to hear all these stories. But I do get people who who just don't think it's a problem. I mean, they're willing to call me and ask me a question, but not their doctor.
Right.
But you want to call your doctor and find out the real answers. You don't just have to look it up on the online.
No.
WebMD or anything like that. Call your doctor.
Or call the breast center and,
Right.
and get an appointment.
We have the answers.
Okay.
Another question. Wally from Salt Lake City. What's your question, Wally?
I just want to know if mammograms cause cancer with all that radiation that you have every year.
Okay, we just talked about that,
Right.
and you said
Well,
it's very minimal.
It's minimal. We don't think that mammograms really do cause breast cancer at all. There may be a slight increased risk, never say never, especially with radiation, but we know that the overall benefit would far outweigh the potential harm that radiation would do. So the answer is no. Mammography really doesn't cause breast cancer. It's a fear that women have, but it really is an unfounded fear. But it's an excellent question because fear of radiation is one of the reasons that women give for not coming in for routine screening mammography. So I appreciate the question and the opportunity to address that head on.
But there are some groups who come out and say radiation causes breast cancer, so don't get mammograms.
Right. But fortunately, that's dying down. There was a big scare in the 70s. Now they're talking about the other harms of mammography. The biggest one that they cite, and the task force cited, was the anxiety associated with that. And what we like to do is we like to diminish the anxiety by getting those women in quickly, by expediting their care, and by doing minimally invasive procedures rather than surgical procedures when we can. And so we want to make the experience as pleasant as possible under the circumstances.
Right, under the circumstances. And I said, don't go online. It is good to go online. I went online and found a lot of questions that I got to ask the doctor. Instead of solving all my problems online, you can take those questions to the doctor and get a lot of things answered. Well, Dr. Parkinson, thanks so much.
Well, thank you,
for
Mary.
being part of this, and we hope we've solved or resolved some of the myths about breast cancer. And again, if you ever have questions, you can always ask one of the great doctors here. Just call. They really do have the answers for you. And we wish you well.
Thank you.